All right, well, we are at 8 a.m. So welcome everybody to our next edition of Medical Grand Rounds. We're delighted to have everyone back. Although we were hoping we would be in person, we are evaluating the circumstances daily, weekly to see what we'll be doing. So for now, we have decided to transition to a virtual platform for our internal speakers, at least through October. We'll be seeing how everything is moving along in the country, making decisions going forward. We do have some external speakers who've been invited, and we're contacting them, asking them for what their preferences are. So stay tuned for that. We may have some limited in-person, socially distanced, mask required presentations, but we will let you know. But I am very delighted today to kick off this academic year's Grand Round series with Dr. Garg from the Division of Nephrology. And to introduce Dr. Garg, we have Dr. Jamali, our Division Chief of Nephrology. Aji?
Good morning, Lynn, and thank you. And good morning, everyone, and welcome to the Department of Medicine's first Grand Rounds of the academic year. It is my distinct pleasure and privilege to introduce Dr. Neetika Garg, Assistant Professor, CHS, who will be presenting our Grand Rounds today. Dr. Garg graduated with her MBBS from the All India Institute of Medical Sciences in New Delhi and completed her residency in internal medicine at Boston University Medical Center in Boston before joining Beth Israel Deaconess Medical Center in Boston for both her nephrology and transplant nephrology fellowships. We were fortunate to recruit Dr. Garg at the rank of Assistant Professor CHS in 2016. Dr. Garg's area of expertise is living donation and medical complications of kidney transplantation. She has 3 key leadership roles at UW Health, including Associate Director of the Living Kidney Donor Transplantation Program, Director of the High Immunological Risk Kidney Transplant Clinic, and Dyad Lead for the Inpatient Transplant Service. With more than 70 publications in peer-reviewed journals, including 50 since she joined us 5 years ago, Dr. Garg has already become a national authority in the areas of live donor kidney transplantation and antibody-mediated processes. She is a principal investigator or co-investigator on more than 10 clinical studies and trials funded by the NIH and the industry. And she's a member of national committees leading our efforts to improve the rates and outcomes of living donor kidney transplantation. Dr. Garg has already a large number of awards, including the Certificate of Excellence in Tutoring by the Academy at Harvard Medical School, and most recently, the Top Nephrologist 2021 by Wisconsin Magazine Top Doctors. But most importantly to me, at a personal level, Dr. Garg is one of the brightest, most humble servant leaders I have had the honor to work with. She's highly respected by her colleagues, our learners, the leaders of the UW Transplant Center, and certainly her patients. Dr. Garg, thank you for taking the time to share your work and thoughts on living donor kidney transplantation and the evaluation of kidney function in this group of patients. Thank you, and the platform is yours.
Thank you, Dr. Jamali, for the extremely kind introduction. Thank you to Gretchen Olson and Clint Thayer for walking me through the steps to get ready for today. And hello to everyone who's attending this morning. This is my disclosure slide, and I will not be discussing the off-label use of any drug. So I will start with a case study that is fairly representative of what we encounter on a daily basis, and that you may have actually encountered in your practice. A 60-year-old mother is a potential donor for her 30-year-old son. Her estimated GFR is 78 mils per minute per 1.73 meters square. Her unadjusted creatinine clearance is 85 mils per minute. So this is what we get from the 24-hour urine collection. Her body surface area is 1.6 meters square, and her adjusted creatinine clearance is 92 mils per minute per 1.73 meters square. And the question we have is, can she be a kidney donor? I will use this example, this case study, as I go through the different sections of my talk. So I'll be talking about the importance of GFR assessment in living kidney donor candidates, the different methods of GFR assessment, and I'll hone in on the statistical concepts of bias and accuracy. And then lastly, what selection criteria based on GFR we use for donor selection. And these three sections of my talk are aligned with my three learning objectives for this talk. So starting with the importance of GFR assessment in living kidney donor candidates. So we in the US have nearly 150,000 candidates waiting for a kidney transplant, and this number has stayed steady or increased a little bit over the last 7-8 years. We know that living donor kidney transplant is the best kidney replacement therapy option for eligible patients with end-stage kidney failure. Recognition of benefits of living donor transplantation to recipients and to society as a whole has led to efforts to promote living donation at various levels, educating patients and healthcare providers, helping transplant candidates identify and approach potential donors, institution of kidney pair donation programs, acceptance of medically complex candidates, and last but not the least, navigating efficiency and financial barriers to donation. We know living donor transplant is better because patients get an earlier transplant, and it is associated with better patient and allograft outcomes. Ensuring success of the practice of living donation depends on ensuring the safety and good outcomes in our actual living kidney donors, which ultimately relies on thorough evaluation and careful risk assessment before donation. And I'm sure most, if not all of you, have probably come across patients who either need a kidney transplant or have had a kidney transplant or want to donate a kidney. So next, I'll outline our usual approach to the medical component of a living kidney donor evaluation. So the GFR, the glomerular filtration rate, hematuria, proteinuria, so variables directly related to the kidney, speak to the health of the kidney at the time of evaluation, which is relevant both for risk assessment of the donor candidate and also for assessment of the kidney mass, the nephron mass that will be available to the recipient via transplant. This is a very critical concept, and I'll use an example to highlight this. Let's say we have two individuals who are similar in every other which way, but the person on the left has a body surface area of 1.5 meters square, so smaller than average, and the person on the right has a body surface area of 2 meters square, so bigger than average. Let's say both have a body surface area adjusted GFR of 100 mils per minute per 1.73 meters square. Adjusting any GFR measure for body surface area allows using the same GFR thresholds across the range of body size for decision-making regarding donor selection. So from a donor standpoint, both of these donors have equally good kidney function. But let's calculate their unadjusted or their absolute kidney function. And for the smaller person on the left, as you can imagine, the total kidney function, the absolute kidney function is 87 mils per minute. And for the other person on the right, the bigger person, it's 116 mils per minute. So in this case, the smaller donor on the left has less absolute kidney function to offer to a recipient compared to the person on the right, even though their body surface area adjusted GFR is exactly the same. So to summarize, body surface area adjusted GFR is relevant to donor safety, donor outcomes, and the absolute GFR is relevant to outcomes in the recipient in terms of how much kidney function will be available to the recipient after transplant. So if we look at our case study, the two BSA adjusted measures, estimated GFR and adjusted creatinine clearance, are relevant to outcomes in the mother, the donor after donation, and the unadjusted creatinine clearance, the 85 mils per minute, will be relevant to the recipient, the son, after donation. So as I said earlier, GFR and proteinuria speak to the health of the kidney at the time of evaluation, and it is relevant to both the donor and the recipient. And the systemic and the genetic risk factors highlighted on this side, for example, blood pressure, glucose, body mass index, smoking, family history, genetics, they may or may not have had the chance to have a bearing on the kidney function at the time of evaluation and donation and transplantation, but are important to long-term outcomes in the donor after the donation has actually happened. And for purposes of this talk, I'll be mostly focusing on the GFR of the donor. So what happens to the GFR in the donor after the donation has occurred? Donor nephrectomy is followed by adaptive hyperfiltration in the remaining kidney, and we ultimately achieve about 70% of pre-donation kidney function. So right after the donation has occurred, as expected, the donor has 50% kidney function, but over time, as a result of adaptive hyperfiltration, you get to up to 70-ish%. There are several studies that have evaluated post-donation GFR trends. This figure is from one of the studies published about 10 years ago. It showed that kidney function improves for several years post-donation. This phenomena is expected to apply to all donors, irrespective of gender and age at the time of donation. And then after years of increased kidney function, there is progressively decreasing kidney function. And this appears to be more pronounced in the elderly compared to younger individuals. So what does this mean in terms of kidney failure risk? So this graph represents an individual who is not a donor, who develops progressive kidney disease, let's say diabetic nephropathy, and reaches kidney failure in a certain amount of time, as delineated on the x-axis. If the same individual is a donor and goes on to develop the same kidney disease, by virtue of having a lower GFR at the time of the beginning of the disease process, they would reach advanced CKD and end-stage kidney disease sooner than if they had not donated a kidney, resulting in an increased risk of end-stage kidney failure in donors. So to highlight this concept of increased ESKD risk in donors, two sub-studies were published almost simultaneously in 2014 that showed that the relative risk of end-stage kidney failure in donors is increased compared to healthy controls, but the absolute risk remains quite low. Prior to these two studies, several studies had been published which showed that living donors do not have an increased risk of kidney failure. However, they were limited by very small sample sizes or lack of a healthy control group. So the first of the two studies was a US study, which included close to 100,000 kidney donors from the US who had donated between 1994 and 2011. And the study included healthy controls from the enhanced CMS database. So as you can see here, compared to healthy matched non-donors whose risk of kidney failure was only 0.14%, living donors had a risk of ESKD of 0.9%. So about 6.4 times higher, but still less than 1% and still definitely less than unscreened donor in the general population of over 3% in this study. Of note, the median follow-up in the study was 7.6 years. The other study, which was published again in 2014, is from Norway, and it showed that the risk of kidney failure was 11.4 times higher compared to non-donors. This study did have longer follow-up than the US study of almost 15 years, and but it also showed that the absolute risk remains low. So the absolute risk of carefully selected donors, the absolute risk of kidney failure in carefully selected donors is low, but the relative risk associated with donation is still substantial. So how does GFR factor into this post-donation kidney failure risk? So I borrowed this one statistic from a study that was published a couple of years ago. It had about 125,000 US living kidney donors who donated between 1994 and 2016. The median follow-up in this study was 10.3 years, But as you can see, if they donated in 1994, it extended the horizon of our follow-up available for donors to 20 to 25 years for some of the donors. And it showed that every 10 unit increase in eGFR at the time of donation was associated with 11% lower hazards of developing end-stage kidney disease. So to give an example, if you have two 25-year-olds, one with a GFR of 125, one with a GFR of 85, the person with the lower GFR, if you do the math, ends up having a 60% higher risk of kidney failure compared to the person with the higher GFR. So to summarize what I've talked about so far, donor nephrectomy is followed by adaptive hypofiltration in kidney donors to approximately 70% of pre-donation GFR. Kidney donors incur an increased risk of kidney failure after donation. Pre-donation GFR is an important predictor of post-donation outcomes, including kidney failure, and ergo, accurate assessment of kidney function is important in this population. Next, I'll talk about methods of GFR assessment, and hopefully I've demonstrated to you by now why kidney function method measurement is important. And here I have broadly classified the three ways we use to assess GFR. We have estimated GFR, we have measured GFR, and we have creatinine clearance. In humans, true GFR cannot be directly measured. It cannot be known with absolute certainty. However, it can only be assessed, either estimated or measured, using different endogenous or exogenous markers. Before I go into the details of these three methods, I like to talk about two important statistical concepts of bias and accuracy. So what is bias? Bias is how far an assessed value of a variable, GFR in this case, is from the true value of the variable on an average. It is a commonly reported statistic and usually, measured in mean or median. On the other hand, accuracy also tells you the same thing, how far an assessed value is from the true value, but an individual level, not as an average of the whole set of measurements. So this is not as commonly reported in literature, and but the usual units for this are P30, P20, P10. What do these mean? An example of this would be, so if we say P30, it tells us the GFR estimates that are within 30% of the measured GFR. So a high P30 would be good, a low P30 would be bad. Similarly, P10 would be GFR assessments or estimates that are within 10% of the measured GFR or the true GFR, and a high P10 would be good, a low P10 would be a bad measure of the test. So a helpful way to understand these concepts is the dartboard example, where the center of the dartboard represents the true value, the actual GFR. So if you look at this slide, each dot represents an individual measurement. So looking through the example on the left side, if all the measurements are close to the actual value, the center of the dartboard, not only is the average of the deviations from the actual value, i.e. the bias, low, but also each individual measurement is close to the true value. So the accuracy is high. So this represents low bias, high accuracy, which is what we want from a test. Looking at the example on the right side, all measurements are scattered pretty randomly all over the dartboard. So if you average out the deviations from the actual value, bias is still low, but deviations at an individual levels are still pretty substantial. In other words, overall bias is low, but accuracy is also low. And this is what we end up getting from most GFR methods, which I'll go into. Usually when a talk gets heavy on statistics, my concentration starts to fade away. So here's a little humor to pull you back in case I'm starting to lose you. So moving on to methods of GFR assessment, the first thing I'll talk about is estimated GFR. And the first method of estimating GFR I'll talk about is the 2009 CKD EPI equation. So the 2009 CKD-EPI equation, this is the most important figure from this paper. It shows them highlighted with the red arrow and the black line. It shows that the median bias across all range of GFR is pretty low. So if you look at the entire range of GFR, the median bias is only 2.5. And if you look at GFRs above 60, which is what we're mostly dealing with when we talk about living donors, the median bias is only 3.5. So the median bias using this equation that we get is very low. On the other hand, the accuracy is only modest. So P30, remember P30, if it's high, it's good. For the entire range of GFR is 84%, and for GFRs above 60, it's 88%. It seems like a good number, but what it means is more than 1 in 10 donor candidates has a GFR that deviates from the true GFR by more than 30% in each direction. So the bias for the CKD-EPI equation is good, but the accuracy is overall modest. You could easily argue that in the context of living donor eval, allowance of a 30% error in each direction already seems too high. And this follow-up study looked at P10, so a more stringent measure of accuracy than P30. And the P10 for the CKD-EPI equation was only 50% or so. I would be remiss if I didn't talk about the race coefficient, which has spurred a lot of discussion recently on a national level. This is the 2009 CKD-EPI equation noted here on the screen. And as you see here, there is a 16% coefficient for African Americans. So what this means is everything else being equal, African American individuals get a 16% higher GFR than their white counterparts. So what this has, the reason this is a concern is that at an individual level, there is concern that overestimation of GFR in African Americans can lead to disparities in access to nephrology care for this population. And several arguments can be made in favor of removing the coefficient. Race is a social construct, not a biological one. It relies on self-reported race in the electronic medical records, and it does not take into account individuals with multiracial backgrounds. On the other hand, there's also concern that removal of the coefficient might lead to exclusion of African American donor candidates. Of note, the original CKD-EPI cohort from which this equation was derived included nearly 1/3 Blacks. And we do know from the study published in the NEJM cited below that at a population level, removal of the race coefficient does lead to higher bias and reduced accuracy. So in response to these discussions, the National Kidney Foundation and the American Society of Nephrology formed a joint task force to reassess the inclusion of the race variable in the equations that are used to diagnose kidney disease. And their final report or recommendation is actually expected to be out very shortly, but is not available yet. So as you can see, there are pros and cons of removing the race coefficient. This slide shows the results of a very recently published survey that showed how many transplant centers have modified their equation to remove the race coefficient. And it shows that 14% of the centers across the country have already removed the equation, and another 46% are planning to remove. Of note, UW-Madison removed it several months ago and was amongst the first 10 institutions in the country to remove it. But more importantly, at UW now, we have Cystatin C easily available for a relatively less race-dependent way of assessing eGFR. So moving to discussions about Cystatin C, it is another endogenous marker of kidney function. The reason it is thought to be better than creatinine is because it's less dependent on diet and muscle mass. And I've shown a snapshot of what it looks like in HealthLink. Just like creatinine, it's a number, and then there's an eGFR estimate provided to you based on the cystatin C. Next, I'll talk a little bit about the 2012, not 12 CKD-EPI equation, which incorporates both creatinine and cystatin C. So this equation using combination of creatinine and cystatin C provides improved but still somewhat modest accuracy for the purposes of living donor assessment. The P30, where the P30 for this equation for GFRs greater than 90 is excellent at 97.7%, but the P20 is 83.8%. So this equation definitely has improved performance measures over the 2009 CKD equation, but still somewhat modest accuracy in the context of living donor evaluation that we're looking for. So cystatin C is less dependent on diet and muscle mass. It is also less dependent on race. If you remember, the race coefficient for the creatinine-based equation was 16%. The coefficient for this equation is only 8%. So still dependent on race, but changes less with age compared to what you would expect from the creatinine-based equation. Accuracy is improved, but still somewhat modest. And if I have to summarize the eGFR CKD-EPI equations, this this perfectly summarizes the performance of these equations in the context of living donor evaluations for me. Overall bias is low, but the accuracy offered is less than ideal. So to summarize this section, the CKD-EPI equation, which combines creatinine and cystatin C, offers better performance compared to just creatinine alone. And this is what we are now starting to use in our living donor evaluations. Overall, all the eGFR estimates actually underestimate the actual GFR. And there is a need for race-free equations. However, there's also concern that if we just remove the race coefficient from the existing equations, it may lead to undue exclusion of Black donor candidates. So moving on to measured GFR, which utilizes exogenous filtration markers. So creatinine and cystatin C are endogenous filtration markers. Measured GFR utilizes exogenous filtration markers. There are broadly classifying, there are two ways of assessing these: renal clearance and plasma clearance. The performance characteristics of the renal clearance methods are invariably better than the plasma clearance methods. However, due to ease of performance, plasma clearance methods end up being more commonly utilized, including at the UW, where we use a plasma clearance method. So what exogenous markers can we use? So historically, as you all know, the urinary inulin clearance is considered the gold standard. It is freely filtered in the glomerulus, is not secreted or reabsorbed in the kidney. However, unfortunately, it's available at a very few centers over the world and is not at all available in the US. And I think recently there were some serious adverse events reported in relation to its use in France, leading to its withdrawal in France as well. Also, the methodology for urine inulin clearance is quite rigorous. It requires continuous IV infusion. It has to be carefully timed, repeat blood and urine samples. So what we have currently available include chromium, labeled chromium EDTA, DTPA, iohexol, and iothalamate. And at the UW, DTPA is what we use. So measured GFR, as you know, has been considered the gold standard for GFR assessment and is frequently used in kidney donor candidates. And this slide shows the accuracy, the P30, the P10 of the various methods in reference to renal inulin clearance, which is the ultimate gold standard. So I've highlighted the renal clearance methods in the purple and the plasma clearance methods in the red color. And you can see the performance characteristics, as I noted earlier, are generally better for renal clearance methods compared to plasma clearance methods. but also, as I said earlier, plasma clearance methods tend to be more commonly used here at the UW and all over the country. At the UW, we use the DTPA plasma clearance method. And if you look through the P30 numbers for the plasma clearance methods, they're actually at par with the estimating equations we discussed earlier, even though this methodology is considered the gold standard, hence the title gold standard, but all that glitters is not gold. So this was our discussion about measured GFR. Moving on to creatinine clearance, and I have a picture of a urine jug here because this is what we tell our donor candidates to collect their 24-hour urine in. So in the US, as per organ procurement transplantation network rules, either creatinine clearance or measured GFR is required for kidney function assessment in donor candidates. And this slide represents the result of a survey of US transplant centers we did a couple of years ago. The black bar represent the results of our survey, and the gray bars represents the results of a survey done about 12 years prior. We asked which methods of GFR assessment are routinely used by all centers. And as you can see, creatinine clearance has been and remains the most commonly used method for GFR assessments in the country. So creatinine clearance entails having a 24-hour urine collection from the donor candidate, and two key limitations of this methodology are to be noted. One, there is distal excretion of creatinine in the distal convoluted tubule, so this leads to overestimation of GFR by roughly about 10%, creating a positive bias. So in other words, it overestimates GFR. Remember, eGFR underestimates GFR, creatinine clearance usually overestimates GFR. And then second, we want our donors to collect all the urine made over 24 hours, but we do have some enthusiastic donors who go over to 26, 27 hours, and then some donors who miss a few urine samples in here and there. And briefly speaking, our methods to assess the accuracy of these collections are not perfect. So since creatinine clearance overestimates and eGFR underestimates, we did a study to see if the average of creatinine clearance and eGFR helps us get to a better estimate of kidney function. In this study, we had over 1,000 kidney donors, all of whom who had measured GFRs available. And as you can see highlighted in red, the average of the two measures, creatinine clearance and estimated GFR, actually eliminated essentially all bias in assessment of kidney function. As is to be expected, the accuracy still remained modest, but there was pretty much no bias on an average using the average of the two methods. So to summarize this section on measured GFR and creatinine clearance, either measured GFR or creatinine clearance is required by the OPTN in kidney donor candidates. Measured GFR is considered the gold standard, but the performance really depends on which marker is used, what methodology is used. In general, renal clearance tends to be better than plasma clearance. However, creatinine clearance remains the most commonly used method in the country. Creatinine clearance overestimates estimated GFR, underestimates the true GFR, and using the average of the two essentially eliminates bias, but the accuracy still remains modest. So going back to our case study, in this case, we did not measure the GFR. We did not get a measured GFR. And as expected, based on our prior conversation, eGFR is less than the creatinine clearance. And in the absence of a measured GFR, the average of the two, which comes out to 85 mils per minute per 1.73 meters square, provides the best estimate of her true kidney function. So I like this joke, and I wanted to share this before moving on to the last section, where I discuss GFR-based donor selection criteria. So far, we have discussed that donor kidney function assessment is important, the various methods of GFR assessment and their limitations. Next, I will discuss how we use these assessments, the numbers we have received so far, to determine eligibility for donation. So going back to the survey study that we did, we also asked US donor candidates what criteria they use for exclusion of donor candidates. And we found that 3/4 of the centers in the country use a fixed cutoff of 80, and only 1/4 of the centers in the country use GFR thresholds calibrated for age. Next, I'll discuss why this is important. So the biggest concern with using a fixed cutoff is that GFR declines with healthy aging, not just aging, with healthy aging. And this is one of the studies which shows this. As you can see, as you age, your kidney function goes down, and this applies to both men and women. And the thought process is that using body surface area adjusted GFR values, 2 standard deviations or below mean for age as a threshold under which candidates are deemed eligible seems to be a reasonable way to ensure that the actual kidney donors that we're selecting have normal kidney function or kidney function within a healthy range. So I'll go back to the previous example where we talked about 2 25-year-olds, one with a kidney function of 125 mils per minute per 1.73 meters square, and another with a kidney function of 85. And we said that based on our knowledge of the relevance of kidney function in donor candidates, the person with the lower GFR has 60% higher risk of end-stage kidney failure. So if we apply the fixed cutoff of 80 to both these donor candidates, they would both be eligible to proceed with donation. However, if we look at the normal GFR for age, as highlighted in this table, it provides the mean for an age of 25. The mean GFR is 123, and the standard deviation is 16. So 2 standard deviations below mean for this age group is 91. So if we apply age calibrated criteria to these 2 donors, 2 standard deviations below mean, the donor with the GFR of 125 mils per minute would be appropriately cleared to donate. And on the other hand, the donor with the GFR of 85, which is below 2 standard deviations for below mean for his age group, i.e. 91, would not be cleared to donate. So this highlights the problems with use of fixed GFR criteria for acceptance or exclusion of donor candidates. The concern is that if we have a fixed criteria, it leads to inappropriate exclusion of younger candidates who have lower GFR. As a corollary, it also leads to inappropriate exclusion of older candidates. If we have a 70-year-old whose GFR is, let's say, 75, we do know that that is within 2 standard deviations of what is expected for his or her age, but that donor might get excluded because the number is less than 80. So use of fixed GFR criteria can lead to inappropriate acceptance of younger candidates and inappropriate exclusion of older candidates. And we advocate use of age-calibrated GFR criteria. Along this line of reasoning, all major guidelines published in the last 10 years, including those from the British Transplantation Society, the Canadian Society of Transplantation, and the European Renal Best Practice guidelines, all these major guidelines incorporate age-specific criteria. The body in the US that makes these recommendations is the OPTN, the Organ Procurement and Transplantation Network. And one exception to these guidelines is that our OPTN does not have any specific recommendations in terms of what criteria to use for acceptance of donor candidates based on their GFR. And then the KDIGO, which is an international body, published its guidelines in 2017. They recommended use of fixed cutoffs of 60 and 90. So 60, less than 60 donors should be excluded. More than 90 is acceptable. And the decision to approve donor candidates with GFR between 60 and 89 should be individualized based on their demographic and health profile in relation to the transplant program's acceptable risk threshold. So this is a slightly complicated concept, and I have outlined this paradigm in this slide where we see 3 donor candidates. The height of the bar or the y-axis represents the projected lifetime risk of kidney failure. And if you look at the 3 candidates, the blue represents the demographic related risk of kidney failure in the absence of donation. Then the orange segment of the bar represents the risk related to their health characteristics in the absence of donation. So related to their GFR, related to their blood pressure, their obesity status, their smoking status. And then the brown represents their donation attributable risk. And the KDIGO suggests that each transplant center have their predefined risk acceptance threshold. And if the donor candidate's risk is above that threshold, we exclude the donor. And if the risk is below that threshold, we accept the donor candidate, but the candidate decides whether they want to proceed or not. This is a very laudable goal, but the biggest question is, how does the KDIGO suggest we estimate this risk? So to this effect, they provide a web-based tool or calculator that was developed using 7 general population cohort with nearly 5 million participants. So here is our example of this, what this calculator might look like. If we plug in the variables related to the 60-year-old white woman, whose example we've been discussing, let's say she doesn't have high blood pressure or diabetes or microalbuminuria and doesn't smoke, we get very low ESKD risk estimates in the absence of donation. So these are the numbers we get: 0.07% 15-year risk and 0.13% lifetime risk. But notably, these are in the absence of donation. And as highlighted by these question marks, this tool, this calculator, does not provide post-donation risks. So the KDIGO 2017 approach has some limitations. To list a few, this calculator was derived using a cohort with a median follow-up of only 6.4 years. So there's concern that if you follow donors only for 6.4 years, you'll get an underestimation of ESKD risk. Extrapolations of post-donation ESKD risk based on the first decade of follow-up will substantially underestimate the risk of end-stage kidney disease in subsequent decades, especially for diseases that have delayed expression and then a long prodrome, like hypertension and diabetes, which are the most common causes of kidney failure. Second, this calculator, this tool provides risk estimates in the absence of donation, not with donation. So that is left to the individual provider's judgment. And third, it incorporates about 10 variables, but lacks important variables like family history and a lot of other details that we go through when we actually evaluate donors. So going back to our case study, so our best estimate of our kidney function, the mother's, is 85 mils per minute per 1.73 meters square. The first question is kidney function adequate for the donor? Can she proceed with donation? And going back to this table, which highlights the normal GFRs for age, our donor candidate's kidney function is within 1 standard deviation for her age. So based on this, I'll say yes, she can, her kidney function is adequate, and yes, she can be a donor. The second, somewhat more complicated question is this kidney function adequate for the intended recipient? And like for a lot of other questions in medicine, the answer is it depends. So as we discussed earlier, BSA adjusted GFR is relevant to the donor. And if we calculate the absolute GFR, because her body surface area is 1.6 meters squares, she's smaller than the average, her absolute GFR comes out to 79 mils per minute. So what are her options? She could proceed with direct donation to her son. In this case, we would expect the son to get roughly half of his mom's GFR, which comes to about 40 mils per minute, since he would get one of the 2 kidneys. However, a lot of variables get taken into account at the time of transplantation. In addition to GFR, we have donor age, blood group, HLA typing, and any incompatibilities related to that. And another option for this pair is to go through kidney pair donation. So to just build on a few variables, let's say the mother's blood type is O, and we already know her absolute GFR is 79. And let's say the son's blood type is A. So kidney pair donation means we look for another pair of donor recipient where there's where they may be seeking a different donor. So let's envision the second pair where the donor's blood type is A and the absolute GFR is 120, so much higher than the mother, and the recipient's blood type is O. In the case of the second pair, the donor B is not able to donate directly to recipient B because of blood group incompatibility. So one option would be if the mother donates to recipient B, and that would be a ABO compatible transplant from blood type O to blood type O, and the donor B donates to the son, which would again be ABO compatible A to A, but the son would get a much higher GFR from this donor as compared to his mother, which would be 120. So half of 120 would be 60. So 20 points higher at 60 compared to 40. So to summarize what we've talked about, pre-donation GFR is a predictor of post-donation outcomes in donors, including end-stage kidney disease. Most clinically available GFR estimation and measurement methods have limited accuracy. In general, the estimated GFRs underestimate GFR and creatinine clearance because of the distal secretion in the distal convoluted tubule overestimates GFR. In the US, creatinine clearance or measured GFR is required for assessment of kidney function in donor candidates. Creatinine clearance is the most commonly used method, although measured GFR is being increasingly used. From a donor standpoint, we recommend the use of body surface area adjusted, age calibrated GFR criteria. From the recipient standpoint, it's the absolute GFR that matters. And UW is a very big kidney pair donation center, and with overall increasing use of kidney pair donation, which offers the option to find a better donor, so to speak, for a particular recipient, this further underscores the importance of a good assessment of the donor GFR. I want to end by acknowledging Dr. Didier Mailroth, who's guided me through most of my research on living kidney donation, and Dr. Jamali, who has been a very supportive division chief and a guide and a mentor throughout my years here at the UW. Thank you so much for listening, and I'm happy to take any questions that might have come up.
Great. Thank you so much, Dr. Garg. There's a couple of questions. First question is, why is DTPA used at UW if iohexol is better studied and improved accuracy compared to DTPA?
That's a really good question. The measured GFR methods, so this has been in place at the UW for a while, and I wish I had a good answer to the question, but this hasn't been in place at the UW since I started here, and it's something that outside of kidney donor evaluation has limited applicability. So it would be very hard to change the methodology we have with the radiology department. In fact, even the availability of that test varies over time. I think sometime last year at the beginning of the pandemic, there was a time period for several months when we didn't have this test available. So we had to send a lot of our donor candidates to other centers for testing. But that's a really good question, and I'm not sure I have a great answer to that question.
Okay, probably need to do some digging into the history. I'm sure there's some practical reason. Then is the error in GFR estimation random? If you did repeated measures, would that improve its accuracy?
Yeah, so that's a good question. So the error in GFR estimation It's random, but it's also always an underestimation. The issue of repeated measurement gets at the concept of precision in addition to accuracy. And yes, it's a yes and no answer. If you get two measurements that are very different from each other, you don't really know what to do with them. But yes, from a statistical standpoint, you could say that it improves accuracy. Yeah.
Okay, great. Interesting question from Aji. Do physicians, are physicians more likely to donate a kidney than non-physicians, or less likely to donate a kidney than non-physicians?
So I know of, I don't know, 3-4 physicians who want to donate a kidney. It depends on whether we're talking about direct donation or indirect donation. I would think that, you know, if somebody in my family needed a kidney, and since I have somewhat of an understanding of what this entails, I would hesitate maybe potentially less to donate than some of my other family members. But physicians also have a busier lifestyle, and I don't know if indirect donation fits that easily into our lifestyle as compared to some of the other individuals. I'm not saying other people are less busy. I'm just making it up as I go, but that's a really interesting question. I don't have any data to support my answer, but I would think that in terms of direct donation, if needed, physicians might be able to better understand the concepts and potentially donate. Good question, not a great answer.
So I have a question. Does the kidney have any regenerative properties after, is it like a partial nephrectomy? Is it all hyperplasia, or can there be actual regeneration?
No, there isn't actual regeneration in the kidney to any extent. So the liver donors, you know, the living donors have some regeneration of the liver. In contrast, the kidney doesn't actually regenerate at all whatsoever. It's the working overtime of the remaining kidney that explains the increase in GFR. So hyperplasia, hyperfiltration, but not actual increase in number of glomeruli.
Is there any work in growing a kidney in a chip or test tube for to increase the availability of organs?
That definitely. So at my previous institution, Beth Israel Deaconess, this was something that was being done for polycystic kidney disease patients. Their own cells, skin tissue was actually being taken to grow essentially layers of renal tubular epithelial cells on chips. But these were layers of renal tubular epithelial cells on chips. They weren't actual kidneys. They weren't bean shaped. They were chip shaped. So there is work being done, but in very early stages. Yes.
Okay, great.
It's like a parallel to the other question we often get in clinic is when is the artificial kidney going to become available? So both the answer to both these questions is a lot of work is being done. I do know that the NIH has been very interested in funding both of these areas of research, but a lot of this is very far away from actual clinical applicability.
Okay. How does the general public learn about paired donation program?
So it is pretty surprising how open donors have been to this. So if somebody comes with the intention of donating to a particular recipient, they learn it usually from us because there isn't a reason they would have looked into this. They come in and they get evaluated, and we tell them that it's okay if you are not able to donate directly to your recipient, but you're a healthy donor. We can still help you find we can still help your intended recipient find a donor who would be able to donate directly to them. Every now and then recipients ask us questions. I have a brother who can donate, but he's not the same blood type as me. And we educate the recipients, and they disseminate that educational material to their family members. So sometimes it's direct education to the donor. Sometimes it's indirect education via the recipient. At UW-Madison, we do have a lot of humanitarian donors, non-directed donors who do not have an intended recipient in mind. And they generally do a lot of their reading before coming in. and they are familiar with the national kidney pair donation programs that we have access to that allow them to, donate to the world, essentially to maximize the benefit from donating that kidney. So if we have a non-directed humanitarian donor who just donates to, who wants to donate, and if, let's say, that kidney gets allocated to whosoever is at the top of the list, only one recipient gets benefit from that donation. If we have a non-directed donor who enters into these pair donation programs, there are algorithms that can help, really maximize the benefit from that kidney. So allocate that kidney to somebody who they're a perfect match with. Allocate that kidney to somebody who's very highly sensitized and can accept only very few kidneys. And most of these donors end up starting chains, which can lead to a lot more transplant than just the one. So in terms of how they learn, it's usually, in the case of direct donation, through the recipient or through the program. And in the case of, indirect donation, it is through generally their whole reading. There's several books, several podcasts, several, interviews that are available that people quote when they come and talk about this. But yes, there are several sources on social media and in the general public information domain that people have access to get this information.
Great. So why does GFR decrease with healthy aging? Are you losing kidney tissue? Is the cells not working as well?
Yeah, so it's loss of kidney, cells dying essentially in the process. So some glomerulosclerosis happens over time, some fibrosis happens over time. So it's actual deterioration in kidney function.
Loss of kidney time.
Yeah.
What is the cost of cystatin C versus creatinine?
Yeah, that's a good question. I had looked into it a few months ago, and it's actually not that expensive. I think cystatin C is about $70. So pretty much at par with what creatinine costs. It wouldn't be cost effective to get it, in terms of how we are using it. If somebody's admitted with AKI, it wouldn't make sense to get a cystatin C every time you get a creatinine. They would give you the same information. But if you're following somebody in clinic and you want to get a sense of their kidney function outside of what the creatinine gives us, getting a one-time cystatin C or getting it every few months does sound reasonable to me.
Okay. And then finally, just to let you know that while we are not in person, we do have donuts. So we have donuts that are on the 5th floor kitchen in MFCB. So please come on by and pick up some nutrition. We are hopeful that we'll be able to see everybody in person at some point in the near future. So with that, I want to thank everyone we'll see you next week. Next week's Grand Rounds is Dr. Nasya Safdar to give us an update on the beginning and the end of the beginning of the end of COVID-19. Thank you all. Have a great weekend. Take care.
Thank you, everybody.